Medurstand Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today I'm going to talk about the role of SGLT2 inhibitors beyond glycemic control. And this is just to remind you that I've already covered a video and made one, and this is actually second of the series of two. And in the earlier video, I emphasized the role of SGLT2 inhibitors in the glycemic control of diabetes. And as you all know that this class of drug has got many benefits which are above glycemic control. So I think this video was necessary. So this agenda, the one in gray, has already been covered. If somebody is interested, he is referred to see my earlier video. But in this one, I'm going to talk about EMPA-REG outcome trial, EMPA-REG renal trial, Emperor reduced trial, Emperor preserved trial, impact on guidelines, because these trials have changed our practice and they have affected some guidelines. So I briefly cover that, and finally I will present conclusions. So if you just take up this class of drug, any drug has got some strong points, the upside, and everything in this world has the downside, and drugs are no exemptions. So I think let me just emphasize the upside. SGLT2 inhibitors, particularly empagliflozin, it has got very good modest HbA1c lowering effect, approximately 1%, and it is mostly very convenient to take. Mostly it is once a day, unless we combine it with metformin. Since metformin is usually twice a day, then this will also be taken twice a day along with metformin. Although now we have XR formulation of metformin, and that can be taken with empagliflozin as once a day. As monotherapy, no hypoglycemia at all. The risk of hypoglycemia is equivalent to placebo as monotherapy. Modest weight loss, especially if patient is motivated and is advised to do some exercise and control his diet also. This medicine will definitely help him or her to lose some weight, because you are actually losing some calories through your urine. It pairs perfectly well with other drugs, particularly metformin. And why particularly metformin? Because metformin is, generally speaking, first-line drug. So if metformin fails to achieve glycemic control, or somebody has some additional kidney-related problem, heart-related problem, then we use empagliflozin earlier on, so it will combine with metformin very well. Another drug worth mentioning here, which it combines well, is GLP-1 receptor agonist, and it has got favorable cardiovascular and renal effects. The downside, it causes polyuria. In some it may cause modest, in some it may be just minimal, in other it may cause massive polyuria. So it varies actually. And if patient is not advised to take water, then patient may develop dehydration, and occasionally there could be renal shutdown also. And DKA is one complication, although the risk of DKA is doubled with SGLT2 inhibitors. But since the incidence of DKA in type 2 diabetes is very low, even doubling does not should stop you from prescribing this medicine. Of course, if somebody is on SGLT2 inhibitor, and we have to be very, very vigilant. And this DKA may not present in its classical form. It may have subtle symptomatology, and there may not be frank hyperglycemia. And it is contraindicated if estimated GFR is less than 30. In this class, we prefer to give insulin. Many oral agents are actually contraindicated, not just this one. So out of all this, it is this favorable cardiovascular and renal effect which make this drug and this class of drug, SGLT2 drug, a very, very unique drug and a very good addition to our armamentarium against diabetes. Now, this is particularly relevant because diabetes is characterized by certain complications, and 80% morbidity and mortality comes through cardiovascular and renal complication. So if there is any drug which has got favorable effect on cardiovascular and renal health, I think that would definitely be a very, very welcome drug. And let's examine some of the trials which have shown that empagliflozin has some favorable effect on cardiovascular and renal effects. Right, so this is what we are going to examine in detail. Now, what are the major unmet challenges in type 2 diabetes? We have, I think, about 12 different classes of glucose lowering therapies, some injectable, others oral. And still, diabetes is a challenge. And what are the main challenges which are still unmet? Number one, patient with diabetes, they tend to develop atherosclerotic cardiovascular disease. On the average, the risk of atherosclerotic cardiovascular disease is about 4 to 5 times more than same gender, same age people without diabetes. So that is one major risk. The other one is those patients who has this atherosclerotic cardiovascular disease, they can develop heart failure, or even without these macrovascular disease, people with diabetes are prone to develop heart failure. So that is another unmet challenge in type 2 diabetes. Then there is CKD. These days, the commonest cause of chronic kidney disease and people going for renal transplant and people going for hemodialysis or renal replacement therapy, mostly these patients are diabetic patients. So diabetes remains a major cause of chronic kidney disease. So these are three major unmet challenges, and these collectively, they reduce one's life expectancy by 5 to 10 years. So I think if we can address these, we can expect that the life expectancy and the quality of life of these patients will improve. Uh, do conventional medicines meet these challenges? Not really, at least not to full extent. Some conventional anti-diabetic medication, they have shown some benefit on cardiovascular health, like metformin, but others, they are great at glucose lowering therapy. They may be good in preventing microvascular complication also, but they may not be very, very good in preventing macrovascular complication and the challenges I just listed. And the example is sulfonylurea. But there is some hope now. SGLT2 inhibitors. Two great additions in our armamentarium against diabetes are SGLT2 inhibitors and GLP-1 receptor agonists. So this video is going to focus on SGLT2 inhibitors. This is because these extra glycemic effects are due to pleiotropic effects. And what exactly is pleiotropic effect? That is some effect of a drug which is not exactly the main effect for which we use that, but when we discover the drug has actually many additional effects, and some of these additional effects may have some benefits. So scientists have identified many additional pleiotropic effects in SGLT2 inhibitors which extend benefits which are over and above glycemic benefits. So what are those? I'm just going to give you the list. I cannot go into the details because the time of this video would not allow me to go in the detail. Natriuresis, and because of that, because this is sodium glucose co-transporter inhibitor. So sodium is also excreted, so there would be natriuresis, and that would affect blood pressure. On the average 3 to 4 millimeter of mercury blood pressure reduction, that would reduce cardiac load, and it causes diuresis, but unlike our conventional loop diuretic, it does not cause hypokalemia, and it reduces oxidative stress. It reduces inflammation in various body tissues including the vessels, and they improved endothelial dysfunction. The endothelial dysfunction is reduced, or there is improvement in endothelial function, and endothelial cells, they produce various anti-inflammatory, antioxidants and vasodilator substances. So that is how it helps. Then it shifts metabolism from glucose to fatty acid, particularly in myocytes. Now, this is particularly an advantage if somebody has coronary artery disease and the circulation is compromised. There is an advantage if metabolism is shifted from glucose to fatty acids. Heart prefers to use fatty acids, ketone bodies, because they are more energy efficient. And when oxygen supply is limited, if the metabolism shifted more toward fatty acid, I think that is beneficial. This mechanism perhaps is also at partly contributing to increased risk of DKA. Glucotoxicity on cardiac muscle is reduced, and finally there is correction of tubulo-glomerular interaction. And there is a very complex mechanism how this tubular cells sense sodium and they regulate glomerular pressure, glomerular circulation, afferent the vascular tone and efferent vascular tone, and that is deranged in patients with diabetes, and SGLT2 inhibitors correct that also. This is perhaps the explanation of beneficial effect of SGLT2 inhibitors beyond glycemic control. So let me first present a summary of various trials on various SGLT2 inhibitors. Then I will focus on empagliflozin. We have empagliflozin, we have dapagliflozin, we have canagliflozin. There are some others but not available in our country, or they have just made available, so the local experience is limited. Now let's first examine cardiovascular outcome trial. We have three of them: EMPA-REG outcome trial, which is about empagliflozin; Declare-TIMI 58 trial, this is about dapagliflozin; and Canvas, which is about canagliflozin. And all three trials, they have shown that MACE 3 point, you know all these MACE 3, cardiovascular death, non-fatal MI, and non-fatal cerebrovascular accident. All three individually and collectively as a composite endpoint, they are reduced by all three studies. So that means this cardiovascular benefit is a class effect of these drugs. Now let's see the heart failure trials. EMPEROR-Reduce, this is the empagliflozin in people with heart failure with reduced ejection fraction less than 40, and EMPEROR-Preserved, this is about those people who have preserved ejection fraction, that means above 40, DAPA-HF, and this is DELIVER and CHIEF-HF. So these are about dapagliflozin and canagliflozin, people with heart failure. In these trials, they studied not only the heart failure parameters, but they also studied renal parameters. So cardiovascular hospitalization for heart failure was substantially reduced. In fact, if there is one benefit of these drugs, SGLT2 inhibitors, is on heart failure. Almost all studies have shown that worsening of heart failure and hospitalization for heart failure has been reduced by use of SGLT2 inhibitors. This is because of natriuresis, this is because of reduction in blood pressure, this is because of many of the pleiotropic effect I listed, the vascular health, endothelial function and all that. Then kidney trials, there's some specific trials on kidney, EMPA-REG, renal, DAPA, CKD and credence. All of them, they have shown benefits on incident or worsening nephropathy and progression of microalbuminuria to macroalbuminuria. So all these parameters and the composite endpoints have been shown to be improved with SGLT2 inhibitors. And similar results are reported with sotagliflozin, which is a SGLT1 as well as SGLT2 inhibitors, and orforgliflozin, a relatively newer SGLT2 inhibitor. So have shown similar results. So what I mean by this is that all these benefits are perhaps the class effect of SGLT2 inhibitors. But now we are going to examine empagliflozin in more detail. You know, in 2008, the FDA issued a guidance for pharmaceutical industries that any new drug which is launched must show some glucose lowering effect. That of course will be mandatory because it is a glucose lowering therapy. But they made a requirement that the company must show by doing trial that the drug is safe from cardiovascular point of view. Now, this became relevant because of the experience of rosiglitazone. You all know rosiglitazone, an insulin sensitizer, was effective in lowering glucose, but those people who had existing cardiovascular disease and were given rosiglitazone, in the chances of cardiovascular death increased in them. So it became then very relevant that new drugs must show that they do not have this drug, this side effect on cardiovascular disease. So I think these CWAR trials, and I'm going to show you EMPA-REG trial, demonstrated that empagliflozin is safe from cardiovascular outcome perspective. Not only that, it actually showed some benefits. So I will give double yes to this drug, SGLT2 inhibitor empagliflozin. Not only it is safe from cardiovascular point of view, it actually extends some benefit, which I'm going to show in some trials. And I will of course not be able to go into the details of all trials because one lecture is not enough to cover all these. Now these are the trials. This is about atherosclerotic cardiovascular outcomes, 3-point MACE. This is about the renal outcome. This is about those patients who have heart failure with reduced ejection fraction, and this is heart failure with preserved ejection fraction. Now I'm going to take up all these one by one. Let's first take EMPA-REG outcome. Now, this was published in the New England Journal of Medicine. We all respect. This is very, very reputable journal. Empagliflozin, cardiovascular outcomes and mortality in type 2 diabetes. The objective was to examine the long-term effect of empagliflozin versus placebo in addition to standard of care on CV morbidity and mortality in patients with type 2 diabetes and high risk of CV events. This is the design, 42 centers, 42 countries, 590 sites, randomized, double-blind, placebo-controlled CV outcome trials, adults with type 2 diabetes, BMI equivalent to or more than 45, so they were heavy people, HbA1c 7 to 10%, established cardiovascular disease, prior MI, coronary artery disease, stroke, unstable angina, or occlusive peripheral artery disease. So all these patients, they were at a very, very high risk patient. In fact, they already had atherosclerotic cardiovascular disease. And the key exclusion criteria was people with advanced renal disease characterized by EGFR less than 30. So they were screened, then they were randomized. About 7,000 people were randomized to either to receive placebo in addition to standard of care or empagliflozin 10 milligram a day or empagliflozin 25 milligram a day. So these three arms were studied for several years and they were observed for any MACE-3 composite endpoints. They were studied for cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. These are the three main MACE points, but then any additional component which was relevant, like hospitalization for unstable angina, hospitalization for heart failure, they were also studied. Now, these are the results. Again, very briefly, primary outcome, which is 3-point MACE, composite 3-point MACE, CV death, non-fatal myocardial infarction, and non-fatal stroke. You please appreciate that both curves, they start diverging from each other very early. This is empagliflozin, the red one. This is placebo, and there is over 48 weeks, there was marked difference. And there was 14% reduction, 14% significant reduction in composite 3-point MACE endpoint. And this is the reduction is in addition to their glycemic effect because the standard of care was also given to both groups. So I think very impressive 14%. Then EMPA-REG outcome trial on CV death. Now we're going to take the three MACE points individually. The CV death, even more impressive effect. there is 38% reduction in CV death. Very, very good. So p-value minus less than 0.001. Very, very impressive 38% reduction in CV death. Then hospitalization for heart failure in 48 weeks, people with empagliflozin, they were 35% less likely to get admitted because of worsening of heart failure. Very good p-value. So there again, very, very robust effect. Then all-cause mortality, the, the points fatal stroke, non-fatal stroke, or other mortality, there was some effect, very good effect on that also. So I think on every parameter, empagliflozin showed very robust reduction in the outcomes. So we have covered this one. Now let's see how empagliflozin fares in EMPA-REG renal trial. This was again published in New England Journal of Medicine, Empagliflozin and progression of kidney disease in type 2 diabetes. Very briefly, I think incident or worsening nephropathy was reduced by 39%. Those people who were empagliflozin, there were 39% less chances of developing new nephropathy or worsening nephropathy, progressing from microalbuminuria to macroalbuminuria. Similarly, there were 38% less chances of progression to macroalbuminuria if they were on empagliflozin. And then there was about 46% chances of post hoc composite endpoints, all kidney related. So in this study, empagliflozin in people with type 2 diabetes, the chances of progression of kidney disease, there was very, very robust benefit. So this one we have covered briefly. Now we take up emperor reduced. I've already mentioned EMPA-REG was in, for again, New England Journal of Medicine, cardiovascular and renal outcome. This was primarily for heart failure with reduced ejection fraction, but they also studied renal outcomes with empagliflozin in people with heart failure. And interestingly, the EMPEROR-reduced trial was included people with or without diabetes. Now, this truly emphasizes the fact that this empagliflozin extends benefit not only through glycemic control. If that was true, then people without diabetes would not benefit. So this effect is actually beyond glycemic control, and that is what makes this drug interesting. EMPEROR-reduced trial was designed to evaluate the effects of empagliflozin 10 mg once daily as compared with placebo in patients with heart failure and reduce ejection fraction. Now this is important because 50% patients with heart failure, they have reduced ejection fraction. With or without diabetes, who were already receiving all appropriate treatment for heart failure. They were receiving ACE inhibitors, or ARBs or ARNI or beta blockers or mineralocorticoid receptor antagonists, all conventional treatment of heart failure were already being given to them. So the benefits, if this study shows any benefit, that was above all these drugs. So again, empagliflozin treated patient had lower risk of hospitalization for heart failure. You can see both curves diverging from each other. This is empagliflozin 10 mg, this is placebo, and there is very, very significant reduction, about 30% relative risk reduction in hospitalization for heart failure. So very, very significant observation. Then empagliflozin reduce estimated GFR decline over time versus placebo. You can see initially, this is very, very interesting observation, all SGLT2 inhibitors when used, initially there is dip in GFR. This is perhaps because of change in hemodynamics, reduction in extracellular compartment. But then they extend benefits, like later on they show benefit. You see, people who were on empagliflozin, they had only 0.55 milliliter per minute per 1.73 meter square per year reduction in eGFR. Compared to those who were not on empagliflozin, they had 2.28 milliliter. So the chances of decline in GFR in diabetes was much less if you were on empagliflozin. Now that would of course explain the renal benefits. Empagliflozin was associated with slower progression and decline in renal function in patients who were on empagliflozin. A reduced composite renal endpoint, all points together, and the result was even more impressive. About 50%, those who were on empagliflozin, the 50% lesser chances of composite renal endpoints. So let's examine this part, EMPA-REG, which was, I repeat, this was primarily for those patients who had diabetes and heart failure. They were already receiving heart failure treatment, and their cardiac and renal endpoints were examined, and we are going to study here renal endpoint. So let's see if primary endpoints, the composite of cardiovascular death or heart failure hospitalization, was reduced in this study or not. It was achieved with very good p-value. Secondary endpoints, the total first and recurrent heart failure hospitalization, that was also achieved. And secondary endpoint, decline in glomerular filtration rate over time, that was achieved. So all primary endpoint and all secondary endpoints were met in patients who were treated with empagliflozin, and patients with heart failure and diabetes, and some without heart failure also. So I think very good result from EMPA-REG, and then the last one, EMPA-REG. Now this is particularly important. Why it is particularly important? Because 50% patients with heart failure, they have the so-called preserved ejection fraction. They might have less than normal, but any ejection fraction which is above 40 is called preserved. The conventional treatment is not very effective in patients with preserved ejection fraction. So let's see if empagliflozin can help. Composite of cardiovascular death or hospitalization for heart failure. Now you can see both curves separating from each other, and there is definitely benefit. People on empagliflozin had 13.8% chances of getting hospitalized for heart failure compared to 17.1% in people with placebo. So over and above conventional heart failure treatment, empagliflozin reduces hospitalization in people with heart failure and preserved ejection fraction, a category where other treatments are not very effective. So I think all 4 studies have shown good cardiovascular and renal outcome. Now let's see how these studies had changed our guidelines, the impact on guidelines. Management of hyperglycemia in type 2, a consensus report by the ADA and the EASD. This was first time published in 2018, and it was published in both Diabetologia, which is the journal of European Association of Study of Diabetes, and Diabetes Care, the American Diabetes Association journal. So this is now available online, free. There are some limitations of guidelines, but we apply these guidelines on individuals. We customize. According to that patient, we see what is best for that patient, of course, in view of these guidelines. Then ADA issued its updates, and this was in 2021. if you remember in the last slide, those guidelines were primarily for glycemic control. When it was realized more and more strongly that glycemic control is not just sufficient, we have to address the associated cardiovascular outcome. So they modified and they said the treatment algorithm driven by glycemia. Of course, glycemia remains one of the most important, if not the most important component of diabetes, but they considered cardiovascular disease also. So in view of cardiovascular disease, they made some amendments. And I'm going to present a summary of these amended guidelines. At the time of diagnosis, all individuals are started with lifestyle changes, and those whose A1C is just borderline high, maybe just lifestyle changes, but all others are offered metformin also in an escalating dose. And these bars indicate that they are started with these two and they remain on these two agents till end. Other agents will be added and some will be removed, but lifestyle changes and metformin are continued till end. There are two situations where metformin may be discontinued. One is when patient cannot tolerate, or the other is when patient develops advanced kidney disease. Of course, at GFR 44, we reduce metformin, and when it is below 30, we discontinue or we do not start, but otherwise we continue these two drugs. These are the guidelines. And after that, the recommendations say that immediately after the diagnosis, we need to evaluate these patients from cardiovascular and renal point of view. So there may be three categories. First is those who have atherosclerotic cardiovascular disease or have risks for atherosclerotic cardiac disease, or they have renal failure. The second kidney is those patients who have heart failure or have risk factor for heart failure, or they have CKD, even incipient CKD, like in the form of microscopic or microalbuminuria. Then other patients. So in these patients, you could choose one of the many agents, but of course, in this group also, we consider the fact that people should not develop hypoglycemia and people should not gain weight. So here also, SGLT2 inhibitors amongst DPP4 inhibitors and GLP-1 receptor agonists are candidate. But here, SGLT2 inhibitors would be, I think, treatment of first choice. So guideline says that after starting lifestyle changes and metformin, before waiting for metformin to fail, before going to the maximum dose of metformin, irrespective of their existing HbA1c, these patients should receive GLP-1 receptor agonists or SGLT2 inhibitors, either of the two. Those who have heart failure or those who have CKD, even mildest form, their SGLT2 should be preferred, and if they are not suited, then you can go to GLP-1 receptor. Those who have increased risk of atherosclerotic cardiovascular disease, there I think GLP-1 receptor agonist should be first choice and SGLT2 inhibitors should be given if GLP-1 receptor agonists are not tolerated or not afforded. You know, GLP-1 receptors are very expensive. In our country, I think in these group, I believe SGLT2 inhibitors, particularly Empagliflozin, makes very good sensible choice because that is cheaper, oral patient acceptance is more. And of course, after that, we go on to other therapies like basal insulin and then basal and bolus. So these are current guidelines. To sum up, starting with lifestyle changes and metformin, and those patients who are at a high risk of heart failure, CKD, SGLT2 inhibitors as preferred second-line drug after metformin. You could actually start with metformin and SGLT2 inhibitors in the initial evaluation in treatment naive individuals. Now, European Society of Cardiology, they have gone a step further. They say SGLT2 inhibitors may be used in drug-naive individuals. That means they have been diagnosed diabetic only recently. they have not yet put on medication, so your starting medication may be SGLT2 inhibitors. They do not say that metformin should not be used. They say SGLT2 inhibitors should be used as first-line treatment. This may be combined with metformin. I personally think if there is no contraindication for metformin, I would definitely like to combine, because metformin is great drug, incredibly cheap, incredibly effective, incredibly safe. So SGLT2 inhibitors are equally great. So I might as well combine in these individuals. And even if they do not have any frank heart failure. So how about combination? Combining oral agent with other anti-diabetic agent, there may be sometimes issues, but metformin or this empagliflozin does not have any compatibility issue. It can be combined with metformin or any other anti-diabetic agent. So you can easily combine in one pill or two separate pill as a starting treatment, or later on you could add empagliflozin to metformin without any compatibility issue. Now, if these two drugs are very good in combination, so might as well examine them in to start with combination. Somebody studied this, and this was published in American Diabetes Association journal. Initial combination of empagliflozin and metformin in patients with type 2 diabetes. It showed very impressive 2.1% HbA1c reduction. And empagliflozin alone showed slightly less than 1%. So combination shows 2.1% reduction. So combination makes very good sense. So now coming back to our major unmet challenges in type 2 diabetes, we identified these three: atherosclerotic cardiovascular disease, heart failure, and CKD, all three leading to life expectancy reduction by 5 to 10%. And I have shown you the evidence that SGLT2 inhibitors, when used, can actually help. And all these outcomes, atherosclerotic cardiovascular disease, heart failure, and CKD are significantly reduced, and they reduce the total mortality also. So the life expectancy will also hopefully improve. So if you want to study more, and this is one reference, gliflozin in the management of cardiovascular disease. This is a great summary published recently in May 26, New England Journal of Medicine. You could scan this, and this would give you a copy of a PDF copy. So the conclusion, number one, SGLT2 inhibitors are unique anti-diabetic agents offering glycemic benefits without the risk of hypoglycemia, and weight and BP benefits. These were actually covered in my earlier video. In this video, I showed the evidence that they have cardiovascular benefits and renal benefits in people with type 2 diabetes, with renal disease, with increased atherosclerotic cardiovascular risk, and people with heart failure. So I think these benefits should be extended to outpatient. Preferred first or second line agent in individuals with heart failure, CKD, and atherosclerotic cardiovascular disease. This is now reflected in new guidelines, European Society of Cardiology and ADA guidelines. Pairs perfectly well with other anti-diabetic agents, particularly metformin and GLP-1 receptor agonists. Thank you very much. If you want to learn more information is available on my channel, Medurstand, and this is Professor Aziz-ur-Rehman, and this was a talk about on the platform of Pakistan Society of Internal Medicine and Reach Out Program for Education. This is the subsidiary of Pakistan Society of Internal Medicine. Thank you very much.